Welcome to the Explainer. Today we're taking a macro to micro journey through the pathophysiology of shock and trauma. We're going to literally break down the mechanics of cardiovascular collapse, right down in the microscopic cellular fallout. So let's just jump right in. Here's our pathway for today. 1. Defining types of shock. 2. The body's alarm system. 3. Hormonal and metabolic shifts. 4. Pitfalls in fluid resuscitation. And finally, 5. The immune cascade. Okay, let's dive into this. Section 1. Defining types of shock, and specifically diagnosing the macroscopic insult. All right, here's our first clinical puzzle. Imagine a patient presenting with a large tension pneumothorax. Is the resulting shock categorized as A. Traumatic, B. Vasodilatory, C. Cardiogenic, or D. Obstructive? Think about the actual mechanics going on here. That trapped air inside the chest cavity. What's it actually doing? Well, the answer is D. Obstructive shock. And this is an absolutely crucial distinction. You see, obstructive shock is actually a subform of cardiogenic shock, but it results from a mechanical impediment to circulation. It's like trapped air physically pressing on the vessels. So it's a mechanical blockage, right? Not a primary failure of the heart muscle itself. The pump is fine. The pipes are just squeezed shut. Okay, next scenario. You have a patient with a dangerously low blood pressure of 70/50, high lactate at 30 milligrams per deciliter, and a really low cardiac output of 1.9 liters per minute. But I want you to focus specifically on this last value, an abnormally low central venous pressure of 2 centimeters of water. Which diagnosis fits best? A. Congestive heart failure, B. Cardiac tamponade, C. Hypovolemic shock, or D. Septic shock? The correct answer here is C. Hypovolemic shock. Now, what's really interesting about this is the stark contrast in these pressure readings. In hypovolemic shock, inadequate tissue perfusion is due to actual volume leaving the body. The tank is literally empty, resulting in that low central venous pressure. Conversely, if this were something like congestive heart failure or maybe a pulmonary embolus, an obstructive issue, you'd see a backup of blood, which would drastically elevate that central venous pressure. Moving right along to Section 2, the body's alarm system, and how the nervous system detects the crisis. Now here's a phenomenal exam pearl to explore exactly how our internal sensors react to dropping blood pressure. What is true about baroreceptors? A. They're activated in hemorrhage with low left atrial pressure. B. Receptors in the aortic arch and carotid bodies inhibit the autonomic nervous system when stretched. C. Stretching induces increased autonomic output. Or D. None of the above. The correct answer is B. Baroreceptors, which are hanging out in your aortic arch and carotid bodies, normally inhibit the autonomic nervous system when they're stretched by normal blood pressure. But when trauma causes a massive drop in blood volume, that stretch literally disappears. The inhibition stops and boom, you get a massive spike in sympathetic output. It's like taking your foot off the brakes. Meanwhile, your chemoreceptors sense chemical changes like oxygen, hydrogen ions, and CO2, and they trigger survival reflexes like slowing the heart rate and causing splanchnic vasoconstriction. Let's jump to Section 3, hormonal and metabolic shifts, or as I like to call it, flooding the system for survival. You know, the body ruthlessly prioritizes which organs get blood during a crisis. So, which of the following is true regarding antidiuretic hormone, or ADH, production in injured patients? A. It acts as a potent mesenteric vasoconstrictor. B. It falls to normal in 2 to 3 days. C. It decreases hepatic gluconeogenesis, or D. It's mediated by renin-angiotensin. Think about what ADH actually needs to accomplish during a rapid bleed. If you guessed A, you hit the nail on the head. ADH, or arginine vasopressin, acts as a highly potent mesenteric vasoconstrictor. It literally starves your splanchnic organs, your gut, of blood, intentionally shunting whatever volume is left straight to the brain and the heart. And get this, levels remain elevated for roughly a full week after the insult, all while it's simultaneously signaling the liver to ramp up sugar production. All right, here's another one. Which of the following occurs as a result of epinephrine and norepinephrine release during shock? Does it cause A, hepatic glycogenolysis, B, hypoglycemia, C, insulin sensitivity, or D, lipogenesis? How exactly do these catecholamines alter your body's fuel consumption amidst all this chaos? The correct answer is A. Catecholamines basically force the body into a profoundly catabolic state to mobilize energy. They trigger hepatic glycogenolysis, breaking down stored liver glycogen into instantly usable glucose. And crucially, epinephrine actively inhibits insulin release. So your body is intentionally creating a state of hyperglycemia and insulin resistance. Why? To guarantee there's immediate, usable energy available in the bloodstream, completely disregarding any long-term metabolic costs. Survival mode, right? Okay, moving to section 4, pitfalls in fluid resuscitation. This is all about what happens when our medical interventions actually backfire. So, in a hemorrhage, the sympathetic nervous system normally forces larger arterioles to vasoconstrict, right? But which categories of shock are associated with a paradoxical vasodilation of these larger arterioles? Is it A, septic shock, B, cardiogenic shock, C, neurogenic shock, or D, both A and C? The answer for that last one was D, by the way. Both septic and neurogenic shock completely break the rules and cause pathological vasodilation. Okay, on to the next question regarding resuscitation. When resuscitating hemorrhagic shock with an intravenous colloid solution rather than lactated ringers, all are true except A, circulating immunoglobulins drop, B, binds ionized calcium, C, endogenous albumin drops, or D, extracellular fluid volume deficit is restored. Spot the false statement here. The false statement, the exception, is D, and this is a huge one because it debunks a major medical myth. It's what we call the colloid trap. Because colloid solutions have a higher osmotic pressure, they actually draw extracellular fluid out of the surrounding tissues and into the vascular space. So instead of restoring that extracellular fluid deficit, they literally make it worse. I mean, data shows colloids are really no more effective than crystalloids, they cost more, and using them in bleeding trauma patients can actually be associated with worse outcomes. Crazy, right? Let's head into our final phase, section 5, the immune cascade, the ultimate double-edged sword of inflammation. Let's see if we can pinpoint the microscopic culprit responsible for fatal lung complications after severe trauma. Which cytokine is elevated after shock and plays an absolutely critical role in developing diffuse alveolar damage and ARDS, acute respiratory distress syndrome? Is it A, IL-10, B, TNF-alpha, C, IL-6, or D, IL-1? The correct answer is C, IL-6. Interleukin-6 levels spike aggressively in response to hemorrhagic shock, and these levels directly correlate with overall mortality, specifically because IL-6 is what drives that devastating diffuse alveolar damage and ARDS. Contrast that with IL-10, which functions primarily as an anti-inflammatory cytokine, or TNF-alpha and IL-1, which act as classic early mediators that are way more prominent in septic shock. All right, our final clinical puzzle really asks you to synthesize this entire microscopic battlefield. How exactly does activation of the complement cascade contribute to pro-inflammatory activation following injury and shock? Well, here is the deadly sequence of events. First, you get the activation of complement factors C3A, C4A, and C5A. Second, this induces a massive release of histamine, which causes increased vascular permeability and smooth muscle contraction. But step three is the real kicker. It promotes the physical adherence of neutrophils right onto the vascular endothelium. Your white blood cells literally stick to and damage your own blood vessel walls, leading directly to ARDS and MODS, multiple organ dysfunction syndrome. It's friendly fire on a cellular level. Which brings us to a final, pretty provocative thought. We've seen how the macroscopic injury triggers this overwhelming microscopic response. But if the very immune cascades designed to save us, like IL-6 and complement activation, are ultimately what cause fatal organ failure, where does that leave us? Is the future of trauma care found not just in blindly replacing lost blood, but in finding precise ways to actively suppress our own immune system in those critical first hours? Definitely something to chew on. Thanks for joining me on this explainer, and keep exploring the incredible and sometimes baffling complexities of human physiology.